I mentioned that Wonderfest, that wonder is a primal emotion, and perhaps the first we experience. How about the first sensation we experience? That may very well be pain, whether it's the pain being crowded in the womb or the pain of that doctor's slap on our back. If that's the pain, the kind of pain you experience in your life, you're fine, but it's the chronic pain which can make a tragedy of a lifetime. Here to discuss pain in its many aspects are two great neuroscientists. They are here to talk about, do we understand pain? And I have proper introductory material here to get us off to a good start. Dr. Allan Basbaum is professor and chair of the anatomy department at UCSF, where he conducts research into the neurobiological basis of pain. Professor Basbaum received his MD from the University of Pennsylvania. His honors since then include being elected a fellow of the American Association for the Advancement of Science and a fellow of the Royal Society. Dr. Basbaum has received the Kerr Memorial Award from the American Pain Society and the Bristol-Myers Squibb Prize for Distinguished Pain Research. Dr. Michael Rowbotham is the scientific director of the California Pacific Medical Center Research Institute, CPMC-RI. He received his MD from UCSF and became a full professor there later on, before moving to CPMC. Dr. Rowbotham has authored over 100 peer-reviewed scientific publications. He has helped to establish medical clinics in rural Fiji and in Indonesia following the 2006 earthquake and tsunami. Recently, Dr. Rowbotham received the Wilbert Fordyce Clinical Investigator Award of the American Pain Society. Please join me in welcoming our first speaker, Dr. Allan Basbaum.
Thank you, Tucker. Thank you all for coming. This is going to be fun talking. Actually, when I was in college, I did theater, and I got used to looking right into bright lights. You're not supposed to see the audience, but I usually like to see the audience. So the plan tonight is for me to give you an introduction about the problem of pain, so that we can, to some extent, be on the same page, and then talk about what do we understand, what don't we understand. Mike and I don't entirely disagree, but I think you'll see where the differences arise. And we most importantly want to let you ask questions, and that's how we'll find out what you want to know. We're not here to treat anybody. I like to begin by asking a question, just to illustrate something special about pain. How many people have ever given money philanthropically, say, to the American Cancer Society? Yeah, a lot of people. That's great. How many people have given money to American Arthritis Association? Great. How many people have given to the American Pain Foundation? How about the National Pain Foundation? How about the International Pain Foundation? You did? No, you didn't, because the reason why you didn't is because none of these exist. It's always fun when I ask that question and then 5 people, oh yeah, I gave a lot of money to the American Pain Foundation. It doesn't exist, and there's a reason why it doesn't exist. To be harsh about it, you die often and unfortunately in pain, not of pain. And when something happens, you might die of cancer, and sadly many people do, or you might live a life with severe arthritis or multiple sclerosis, and everyone can empathize and recognize that, and you die and the family wants to do something, wants to advance the field. You can't see pain. You don't die of pain. Pain is very unique. It tends to be thought of as kind of a symptom of something else. I'm going to try to convince you to some extent that pain is a unique problem in and of itself. I like to think of it as a disease, and we'll talk about that. But I'm going to introduce the problem by giving you a little bit of background on about the most basic biology of pain. Not quite what I teach the medical students at UCSF, but so that we understand what we're dealing with. This is our introduction, and the introduction, this was Mike's idea. So I was editor-in-chief of the journal called Pain, which is the journal of the International Association for the Study of Pain, for about 10 years. And it's a miserable job because you have to reject 75% of papers, so 75% of the people in the field don't like you. That's how you start. But the one good thing is I got to pick the covers of the journal. And sometimes they came from articles in the journal. Sometimes we went to, there's something called The Art of Pain, and I would go to that website. And so we're asking the question, do we understand pain? And Mike had the idea, Allan, why don't you try to weave in some of the covers into your little introduction? And that's what I'm going to try to do. So how many people think pain is just basically all bad? Nobody. That's good. Well, some people do. Actually, pain is important. Acute pain is very important. If you don't have acute pain, you could be somebody like this. This is a boy who has what's called congenital insensitivity to pain. He never experiences pain. We actually now know a lot about why that comes about. We don't have time to get into the mechanism. There's a gene defect that can cause this. So that otherwise seem perfectly normal. You can sense heat, you can sense cold, you never experience pain. And what happens if you could have an internal injury, you'd never know it. And so this boy has open injuries, literally have to remove his teeth, otherwise if he bites his nails, he'll literally bite his, amputate his fingers. So acute pain is really important. Now, very simply, let's look at the textbooks. What do the textbooks tell us? How do you generate pain? Very simple, according to the textbooks. What you do is you have a noxious or painful stimulus. That's a stimulus that will produce injury if it were continued. It could be a pinprick, it could be heat, it could be a chemical burn, it could be ice cold, it could be a mechanical stimulus, whatever it is, and that stimulus activates particular nerve fibers in your arm or your leg. Some people call them pain fibers, a very terrible term because pain's a product of the brain, but these are nerve fibers that respond to the stimulus. They carry the information into the spinal cord where it's processed and then goes to the brain, and somehow through some magical event you get pain. That's pretty simple. The sad thing, the anatomy of this pathway that I just described is in fact accurate. The question is that really how you get pain? Now, I like to show this slide. My wife actually tells me that it's time for me to throw out this slide. This is a slide, Descartes, you know, who I think therefore I am Descartes, he actually talked about the problem of pain. He wrote about it. And remarkably, what he proposed, and this was before we knew about nerves, we knew about synapses, we knew about connections, he basically described the same thing. I try to bring it up to date. This is a diagram from somewhere in the 17th century. And what Descartes said is that, little contemporary burn, when you burn the foot B, can everyone in the back see? I just want to be sure. You can. Great. Okay. When you burn the foot B, the information actually travels up. He didn't say travels up because he didn't know nerves. He actually thought there was a little wire that got pulled and it rang a bell in the brain and you got pain. That's not that different from the diagram I just showed you, right? It's just much fancier and you got to buy the textbook, but it's pretty much the same thing. So what's the problem? The problem is that this explains acute pain beautifully. You hurt yourself, you trip, you break a bone, the information comes in, it goes to the brain, ouch, that really hurts. Or even after surgery, the surgeon cuts you open and damages nerves, damages some tissue, and you wake up after and you have pain, so they give you something and everything's cool. Here's one of the beautiful pictures from the journal. It didn't come out all that well here. Somebody pointed, I didn't even notice it, but this University of Kentucky, somebody in the middle of a soccer game got his nose completely broken by a kick in the face. It's a wonderful cover. That's acute pain. That really hurts. We can explain that beautifully. And we can give this person a little bit of morphine or some aspirin-like drugs, and probably their pain will go away and everything's cool. Here's, a lot of people don't like looking at this particular slide. There's a condition called Ehlers syndrome. Now you try this here and I guarantee you it will really hurt. But some people, they don't have proper collagen organization, and so they literally can twist their body into pieces. But if you try it, that's going to really hurt. That's acute pain. We can explain that. Not very interesting, because the clinical problem is not acute pain. How many people ever gave blood? Terrific. Didn't it hurt? Oh, yes, it did. They take this gigantic needle, stick it in your arm. It's very painful. But how many people took morphine in order to treat the pain? Nobody, because you know it's going to go away, and it does go away. That's acute pain. You don't worry about it, all right? The clinical problem is not acute pain. The clinical problem, it's not even post-operative pain by and large. Here's where we might disagree. Michael might disagree with me. The problem is tissue injury-induced chronic pain. Severe arthritis. Now, what's interesting about this particular condition, if the individual doesn't move the fingers, the hand doesn't hurt. What's really abnormal about the clinical problem of pain is that innocuous, normally non-painful stimuli start to hurt. It hurts to move. How many people, I'm already, you know, there's gray hairs here, so I can tell you, I can relate to that. You get up in the morning, it's a little sore, right? It hurts to move. When you were a kid, that didn't happen. That's abnormal. It's because, as you will see, the nervous system changes. And then if you have knee arthritis or hip osteoarthritis and everything is falling apart in that joint, you're going to have serious pain. That's chronic pain. The Descartes picture can't explain that. Can't explain why it hurts to just pick your knee up. Descartes is talking about a painful stimulus experiencing pain. How do you explain the fact that non-painful stimuli now hurt? That's really the clinical problem. Migraine. How many people have migraine? You know, it's actually quite high. It's about 17% of women and 6% of men have migraine. And it's miserable, I'm sure anybody who has it. This is how some of these are artists who try to illustrate their problem. Somebody with a nail digging into their eye. Now, you may never have had migraine, but I think you can somewhat empathize. You can't see their pain, but they can describe it either talking to you or illustrating it. And then this cover of pain, which an artist was trying to illustrate all the different experiences of migraine, nails in the head, a hammer against their head, the head just exploding, etc., etc. This is something that the Cartesian view can't explain. The textbooks don't explain. And then there's the worst type of pain called nerve injury-induced or neuropathic pain. Instead of tissue injury, like muscle and joints, this is where you actually have damage to nerves. And you may know people who have these conditions. They're terrible. Postherpetic neuralgia. Everybody knows what shingles is. Shingles comes from the herpes zoster virus, the same as the chickenpox virus, and you get it, and then you have a very painful condition that can last 6 to 8 weeks with vesicles, swelling. It's very unpleasant, and eventually it resolves. But in 20% of roughly people, they're left with called post-herpetic neuralgia. And Michael is one of the world's experts on this, and I hope he'll talk about it, where the lightest touch to the forehead in this woman will produce excruciating pain. Doesn't respond very well to narcotics. Doesn't respond to aspirin-like drugs, like ibuprofen, which can be very effective for joint pain. You need something different to treat this. The textbooks can't explain it. Complex regional pain syndrome. This individual may have had the slightest nerve damage, and they're left with excruciating burning, pain, hypersensitivity of the foot. And you can obviously see it's discolored, it's swollen. An artist who has this condition sent this figure in to be put on the cover. It's a sculpture. And he's trying to illustrate what he's experiencing. And what he says is that it basically feels like he's got razor blades in his foot all the time. You can't see it. He can describe it. The point is, chronic pain is much more than acute pain. Some people used to think that what chronic pain is just prolonged acute pain, right? It just lasts a lot longer. No, it's something much more complicated. It doesn't arise solely from a lot of activity coming in those pain fibers. Remember the original diagram where we had activity of the pain fiber? And you say, well, chronic pain is just a lot of activity and it never goes away. No, that's not the problem. And I'm going to try to illustrate this to you in a rather dramatic film. The question is, where does this break down? Where does this simple model that the textbooks, and I would say 90% of medical students or nursing students or whatever students are taught throughout the country, they're not taught that at UCSF, this simple diagram, where does it break down such that you need to be able to explain, because it can't explain those conditions I just described, and the conditions that Michael has to deal with. What I want to do is show you a simple movie. Well, not that simple a movie. Something I made many, many years ago. You'll see I was a lot younger. But let's look at a peripheral nerve. I want a little bit of teaching here. Look at a peripheral nerve. I'm going to take your sciatic nerve and I'm just going to cut it and look at it and see what it's made up of. And if you look, this is what it's made up if you do electron microscopy, so you can actually go very high power and look at single nerve fibers. What you basically find is that in any peripheral nerve, it's made up of a variety of fibers. The great majority are so-called unmyelinated fibers. They conduct very slowly. Those are the pain fibers, if you will. They respond to painful stimuli. And then there's a population of small myelinated. They have this sheath around it that allows them to conduct information a little more quickly. They respond to painful stimuli. And the great majority of large fibers, the myelinated fibers, these respond to touch. They respond to moving your joints. They tell you where your body is in the world. They have nothing to do with pain, or so we thought. They do not respond to painful stimuli. The question is, if pain is only accounted for by the activity of the pain fibers, if you will, what would happen, do you think, if I got rid of them? Or if clinically you had a damage that got rid of them? You'd think that it wouldn't make any difference because the pain fibers are still there. The fibers that respond to touch, they're gone, so maybe you won't be able to feel touch. Well, it turns out that I can model that. They don't allow me to do that anymore. They're afraid I'm going to hurt somebody, so I had to make a movie many years ago, and that's what I want to show you. And let's hope that the sound works. So here we have Dana, who is a student in my lab, a long time ago. I put a blood pressure cuff on her arm, and I blew it up above systolic pressure so that there's basically no blood flow. There's no blood flow into her arm. Now, it turns out that the very large fibers, the myelinated, the touch fibers, they have a very high demand for oxygen. So they're going to get blocked very quickly. It's kind of like when your foot falls asleep. Basically the same thing, except it's a little longer. The pain fibers, if you will, they survive. And so it is possible, if you keep the cuff on long enough, and it really doesn't, it's done, when you do orthopedic surgery, it's done all the time, but you know, the school's kind of scared. So they said, don't do it anymore. So in the simplest form, Dana has two types of fibers in her arm. She's got small pain fibers. I put them in quotations because they're not really pain. They're fibers that respond to painful stimuli. They travel up her arm and they go to her spinal cord and they send a message to the brain. And then they've got the large non-pain fibers that are in her arm. They travel up, they go to the spinal cord, and they send information to the brain. You say, oh, touch, I know where my fingers are. Let's see what happens when we shut off the large fibers. Okay? I hope you can hear this. Here we go. Dana has had his blood pressure cuff in her arm. The arm is cyanotic because it's anoxic. Can you move your fingers?
I can flex, I just can't extend.
Okay, you can't extend it. We haven't got a complete block because Dana can flex her fingers a little bit. So almost certainly, There are some large fibers still functioning, but I think the point will still be made, and almost certainly there's some A deltas that are still functioning. If we kept the block on longer, we could eliminate all the myelinated fibers and just have C fibers. But I think the illustration will still be clear. Okay, so the first thing I want you to do is to close your eyes, and we'll just do a very simple neurological test. And I'm going to ask Dana to say touch if she feels when I touch her with this piece of gauze. This is the normal hand.
Yeah, touch. 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 Touch.
Okay, so there's no response to light tactile stimulation. Now let's try joint position sense, conscious joint position sense, which we know is also large fiber mediated dorsal columns, okay?
Mm-hmm.
Okay, I want you to tell me whether the finger is bent down, straight, or up, all right?
Up, up, straight, down, down, straight.
Okay, it's pretty good. All right, let's try this. Nothing? Don't feel it?
I don't feel it.
Okay, large fiber function is gone. Now I'm going to ask a simple question. I'm going to ask Dana, I'm going to use a relatively mild stimulus that would activate C fibers. I'm going to ask somebody in the audience, what does this feel like?
Pinch.
A pinch, okay. All right, Dana, tell me what you feel.
A burning pain.
Where is it?
Well,
Which finger?
I don't know where my hand is, but I felt like it was on the tip of my ring finger.
It was. That's pretty good. So that
But I just don't know where it is.
almost certainly suggests that there is.
There it is.
There it is. Some A delta function. You're doing fine. The A deltas will give you some localized sensation. If the A deltas were not functioning at all, there would be no response. All right? Tell me again. What do you feel this time? Nothing?
Well, no, I feel a little bit of burning pain. Yeah, I feel some burning pain on, it sort of feels like the tips of all my fingers.
All the fingers. Okay. So there really is some poor localization, but the sensation of pinch produced burning. All right? Okay. You all right?
Mm-hmm.
Okay. Tell me what you feel. Tell me whether you feel sharp or dull.
Sharp, dull, sharp.
Feel anything?
No, just a little bit of sort of background burning, but nothing really. I don't feel anything localized. Now I feel a little burning. I think.
Where?
I think on the top of my hand.
Okay. So the pinprick is also producing burning. Okay. Let's try just one more thing. Okay. This is the stimulus. All right. Everyone can see what it is. Tell me what you feel.
Burning pain.
Burning pain. Okay. This is a piece of ice. All right. Dana, I want you to hold this in your right hand. Just what does it feel? Okay. Lose the fibers that respond to light touch. Lose the fibers that respond to light touch. To joint position. They don't respond to pinprick, ice, or pinch. And the perception that is generated by a normally painful stimulus such as pinprick, ice, or pinch is burning. Now, if you ask Michael, when a patient comes in with neuropathic pain, very often they will describe their pain as burning. This basically models it. And what it says is that there's no one pain fiber that is carrying information to the brain. Pain is a product of a lot of processing, and in the setting of injury and damage, as I wrote here, the nervous system is altered. The nervous system, the central nervous system, the spinal cord and brain of the individual with a chronic pain condition has a different nervous system. It's completely different, and it misprocesses in usually a maladaptive way, and you end up with these terrible conditions. This is what I mean by the disease of pain, is that it's an altered nervous system. And we may have time later to tell you how our approach that we're taking, instead of trying to suppress the nervous system, is actually trying to fix the disease by understanding the nature of the change. We don't have that much time to do that today. But it illustrates the point that the Cartesian view, the textbook view of acute pain, can't explain these problems, and probably is the reason why it's so difficult to treat them. You're dealing with an altered nervous system, and you need to understand that nervous system. That's what my laboratory research is all about. Now, the last few slides and I'll move on. Lest we forget, as the bane of pain lies plainly in the brain. There's a famous line from Bertrand Russell, who went to his dentist, and his dentist asked him, well, where does it hurt? And he said, well, in my mind, of course. And he was way ahead of his time. Yes, it does hurt in your mind. It doesn't hurt in your tooth, although I love my wife, but she still doesn't believe me when I tell her the pain's not in her arm. She says, my arm hurts. But yes, you feel it there, but it's a perception of the brain, and it's colored by emotions and experience. That's what makes pain so interesting and so complex. My students took one of my slides behind my back one day, and they made this slide, and they said, no brain, no pain. Which is true, which is true. And we can discuss this because it's so critical to understanding pain, treating the pain patient, is that pain is not just a function of the intensity of the stimulus or where it is. That's part of the experience. Of course you know that it's in your left finger or your right hand, but this is the major piece, the emotional coloring of the pain experience. That's that influences people's lives and destroys their lives. People who can't be treated with chronic pain are miserable, and some of them, unfortunately, can even be suicidal when you cannot treat somebody. I'm not being melodramatic, all right? It is a serious, serious problem. Do we understand it? Of course, I think I understand it. I understand the mechanisms. Michael may disagree because there's a lot of people who aren't being adequately treated, so maybe I don't understand it properly. There are clearly lots of ways to treat pain. That's a pretty painful stimulus, you might think. I'm not about to try it. I like showing this here because it gets me in trouble with. There's always one student every year who's an acupuncturist. This is the patron saint of acupuncture. You probably thought it was Saint Sebastian. It's not. But the point is, I happen to think that acupuncture is a placebo. That doesn't mean it doesn't work, but we can talk about that later. But the fact is that the brain is what's processing this information, and there's every reason to believe that a perception can be influenced by more than just the intensity of a stimulus. This is a cover of pain that is quite compelling. This is a chronic pain patient illustrating what she feels like. She's trapped, isolated, depressed. It's more than just the intensity of the stimulus that this person must deal with. And this is a wonderful slide. It turns out a friend of mine, Vanya Apkarian, did a series of studies, dramatic studies, in chronic back pain patients. And what he found strikingly, and it's been replicated, they're actually brain size volume changes of your brain. Now fortunately they can actually be reversed, but there are areas of the brain that literally change. We don't know exactly the nature of the change, but your brain is so plastic in a positive and negative way. And then somebody replicated. It turns out that these patients, there's something called the gambling task. These patients are very poor at this test. When you have chronic pain, it so influences your decision-making processes. Somebody replicated this and generated this figure in a rat model of back pain, where the rats had analogous thing, and boy, they had the same problem. So it's a good segue into, how good is our preclinical science. And this is my favorite that I'll end with. This is a remarkable painting by a woman who had a stroke. Now you can have severe pain. People don't realize. You think of somebody who's paralyzed after a stroke. Well, many of these patients also have chronic ongoing pain. Same thing after spinal cord injury. She painted this painting, and she the article describes how she said when she painted this painting, it felt like her painting arm was in the freezer, burning ice cold at the same time. However, if she painted the identical painting with a red background, she had no pain at all. Okay, the woman is not nuts, I assure you. It just illustrates the complexity of the problem and why it's so difficult. There is a brain attached to that, and it's processing that input, and it's changing, and that's why it's so difficult. So the question is, do we really understand pain? And I will now turn it over to Michael to tell you whether we do, whether he thinks I do, and thank you.
Okay, so I'm going to go back and pick out some of Allan's slides and make a few comments about them. So when we were setting this up, it was a little difficult because generally we agree. We've known each other for many years, colleagues at UCSF. And and so Allan would frequently send me patients. And as a basic scientist, you know, he cures pain in the lab all the time, repeatedly over the years. But the patients that come to me had often seen 10, 15, 20, I think the record was 39 different physicians to try and get an understanding of what was causing the pain and how to treat it. And one of the first things I learned from my patients was a saying where her way of putting it was, to have pain is to have certainty, to hear about pain is to have doubt. And one of the biggest things biggest areas in trying to understand and manage chronic pain is we really aren't very good at predicting which patients with acute pain are going to go on to get chronic pain. So I'm going to pick one of Allan's slides here, this one, because it's actually a patient of mine. And so she had, first trigeminal division acute zoster. And this is a picture she brought with her to our first clinic visit. So the eye was swollen nearly completely shut. She had these blisters from the shingles virus. And she was now about 6 to 9 months post-infection. Her eye looked pretty normal. She still had some sensory deficit on the forehead and really severe burning pain. And in her particular case, she actually got better. She became pain-free. And she attributed it to acupuncture. I thought it was a combination of that and a couple of medications we tried. But the key thing is that once her pain got better, we were able to withdraw the medications and it never really came back. And in fact, this situation of pain becoming very severe and very established, and then finally, after some treatment, going away and then not coming back, was very intriguing. We decided to study the natural history of patients who'd had acute shingles over the age of 50 and still had pain at least 2 weeks after the initial rash. And that kind of skews your population towards a group that is more likely to get pain. So we had a lot of patients like this with really bad shingles rashes, and many of them looked just like this woman at 3 months. We thought, for sure, going to get bad postherpetic neuralgia, you know, trying different medications. It seems like a hopeless situation. And to our surprise, many patients that looked really bad at 3 months were completely better by 6 months, and almost all of them were better by a year. In fact, at the end of 1 year, only a few still had pain, and almost none of them were taking any medication for it. Even though at 3 months or at 6 months, they still had significant pain and really had a lot of sensory deficit. So one of the hypotheses was that maybe the nerves regrew. Maybe the initial shingles virus reactivation damaged the nerves, which we know to be the case, and these patients who'd recovered from the pain had their nerves regrow. And so then it would be, the scientific question would be, why is it that some patients regrow nerves and some patients don't regrow nerves? So to study this question, what we did was we were taking small skin punch biopsies from the area of pain, and the opposite side where they really don't have any significant pain or sensory impairment. And what we found was, following patients all the way up to 9 years after the shingles outbreak, is the nerves didn't regrow at all. So even when the pain went away completely, the nerve damage was still there. So we not only couldn't predict who was going to end up with chronic pain, we also couldn't really quite understand why it is that in the great majority of patients, the pain terminated itself. In other words, they just got better. It was just a very long and slow process. So that's one of the things that we really still don't understand about chronic pain. And there's many studies that have been ongoing looking at post-surgical pain, different kinds of experimental models, and we still do really quite a poor job of predicting in advance who is going to get chronic pain after some kind of an injury. And in all the different situations, after different kinds of surgery, after fracture, after shingles, the worst case scenario turns out to be after thoracotomy, and that's about 18 or 20% will have persistent pain. But even for shingles, in cases of shingles with a really bad outbreak like this, it's generally on the order of 10, 15% or less will have long-standing pain. So that's one thing we don't understand. Another thing we don't... What, thoracotomy is where you have the ribs spread in order to do like heart surgery or something else, and the intercostal nerves that run under the ribs are often stretched and damaged. And so the patients will get pain. They'll get a constant burning pain, but they'll also get a lot of pain with movement and with breathing. And it's difficult to treat because you can't really stop breathing. You can't really put your rib cage at rest and keep it that way. So another mystery is why is it that sometimes if we get a pain problem under control with a medication, or it can be another intervention like spinal cord stimulation or any one of a number of different things, it works for a while and then it stops working. And we know the person is still taking the medication or still undergoing the treatment, everything is still exactly as it was before, but it just stops working. And the only guess that we really have is that this involves some kind of plasticity where the nervous system at first can't adapt to the medication or the treatment, but after a while it figures a way to going back to that state where they had the chronic pain, and so the pain comes back. And then a third area that is really, I think, been probably the single biggest reason why the pharmaceutical industry has largely abandoned trying to come up with new medications for chronic pain is that the animal models and the early human studies don't tell them which treatments are going to succeed well enough to actually make it through the FDA review and approval process and actually make it to market. And the statistic is that it's under 10% of compounds that actually get to the point where they're just about ready to be tried in people actually make it all the way through. So they work great in the animals, they work great in the animal models. We understand the mechanism of how the drug is working. It seems to work in animal models of chronic pain, but then when you try it in people with long-standing chronic pain, it seems to lose its effect, or you just can't distinguish the effect from placebo. And something that happens in clinical trials is that when you try one of these medications, the first few weeks, the patients being given the active medication are doing much, much better than the patients being given placebo. But then by the end of 3 months or so of treatment, placebo has caught up to the active treatment, the experimental treatment, and so they're no longer distinguishable. So you just get a temporary advantage. And that's something that we really don't understand. Is it that we're choosing the wrong people to be in the studies? Is it that they're being told somehow subliminally what it is that they're getting? We still just don't understand those aspects. So I think maybe at this point, Allan and I will take questions and comments.
I just want to just say that I don't entirely agree with Michael. I love him like a brother. No, I'm kidding. But let's ask this question, because I'm a preclinical scientist, and so Michael has raised the point that, well, yeah, you've got these great models, and the drug companies are dropping out of the field because they say they're just not predictive. They're no good. And I would argue that there's another interpretation to the failure of, if you will, the keyword translation to the clinic. Well, one is the animals are not placebo responders. All right, so there is less of a psychological element, right? In the human, as I emphasized, placebos work, by the way. Don't ever think that just because you give a placebo and it works, therefore there was no pain. That's not true. The placebos work, all right? But there is a brain attached to that individual, and it's interpreting, and so that's part of the failure. The placebo effect on pain is very powerful, and it's difficult to get a good result. And the other one, as you know, Michael, is adverse side effects. A lot of drugs fail not because they don't work, but unfortunately the nervous system is very conservative. Very conservative. The same targets that we want to use to treat pain, like an opiate, morphine. How many people think morphine is a lousy drug? Would you take it? Once, yes. Okay, no. I mean, how many people think you prefer something different than morphine to treat pain? Put it that way. All right, a lot of people put up. All right, morphine happens to be, I think Michael will agree, one of the best drugs to treat severe pain. But how many people have ever had diarrhea? It's interesting, you know, the incidence of diarrhea amongst people in San Francisco is incredibly low. Two people put their hand up. It's like the medical students. I asked them the same question. You've all had it. What do you take for diarrhea? Yes. Imodium. Right? Imodium. You know what Imodium is? It's an opiate. It's a morphine-like drug that just doesn't get into the central nervous system. So it doesn't block pain, but it shuts off your gut. And one of the bad side effects of morphine in patients who are taking high doses for cancer pain is constipation. All right, so in one case, you're trying to induce constipation effectively when you have diarrhea, but if you have pain, you don't want it. But some patients, I think you will agree, will say, look, I'll take the pain, I can't deal with the constipation. So yes, it can be so miserable. So 3 weeks of never, it's bad. So I think, and then the other thing I like to analogize to is cancer. Now, a lot of drugs work to treat cancer models in animals, and then they take them to the human and they turn out they don't work. It is different. The models are not always predictive, and then one of the saddest parts is even for the drugs that work in cancer, as you all know, many of them eventually stop working. That's the problem. It's not that there are a lot of good cancer drugs, it's just that the body becomes resistant. We have ideas why that happens. And maybe it's that the nervous system is adapting to the drugs, just as it may or may not adapt to the pain. I have theories or ideas as to why some patients, I actually did not know that the incidence in postherpetic neuralgia of pain-free individuals was that high. And that's something I just learned from Mike. I didn't know that, because I thought that a lot of patients really, the pain does not disappear. But anyway, I think the nervous system is changing. You have a genetic basis that's different. And all of this is contributing to the individual variability in the type of pain, responsiveness to drugs, etc. So we don't completely agree, I guess.
Dr. Basbaum, you and Dr. Rowbotham have agreed to take a brief break here, because some of you may have an acute need to visit the bathroom. And while we do not have servings of opioids at the counter here, we will allow a break, and you can also pick up some alcohol, which is perhaps a nice painkiller.
But so if you have to pee, the opiate won't help at all, so go ahead.
All right, please come on back, 10-minute break, okay? We'll start the Q&A. Wonderfest is a nonprofit. In that regard, it's a 501c3 nonprofit, which means all of your donations are tax deductible. You might want to consider becoming an ongoing patron of Wonderfest. Go to wonderfest.org and check out the option to fund Wonderfest through a company called Patreon, patreon.org. patreon.com, Wonderfest would welcome your monthly, however tiny, even $1 per month contributions. Please check it out. And there are neat rewards according to the level at which you decide to fund and become a patron of Wonderfest. So, gentlemen, shall we start I'll give Juliana the microphone to get to the questions.
Raise your hand if you've got a question. There's one.
Hello.
Hi.
Can you hear me? Yeah, I am a registered nurse, not practicing right now, but I've been nursing for 36 years. So I understand that both of you do a lot of research, but I don't know how much clinical work you do. Okay. Pardon? Oh, okay. The medical model that we have right now in our state is pretty archaic when it comes to pain, consideration, or control. And I wondered if either of you had any influence or attempted to work with getting more experts in pain control to work in clinical settings, whether it's in acute care hospitals or long-term care or outpatient clinics, to have some say in treating people who have chronic pain. My husband and I were just having this philosophical discussion about the political problems or the law problems with DEA versus, the fears that physicians have. More than once, I've had physicians complain about their patients who complain about pain. And very little do I see, or nurses too. So I don't want to badmouth doctors altogether. Nurses as well are archaic in their viewpoints of pain control. Have any of you worked in the field of trying to bring in more experts into influencing the medical model we have now?
Yeah, so I would say that both of us have. Allan has been very active in the International Association for the Study of Pain for many years, and as the editor for Pain, I worked with Allan as a section editor, and I'm now the treasurer of IASP, and we've both been involved with the American Pain Society. I think in my own specialty in neurology, for reasons that I've never fully understood, very few neurology residents get interested in trying to manage patients with chronic pain. They're really interested in movement disorders or stroke or epilepsy or any one of a number of other subspecialties within neurology, but it's only the rare one that gets interested in treating chronic pain. And part of the reason I've never understood it is because the success rate in treating patients with chronic pain is not as bad as I think the neurology residents think. Now, in general practice, it's hard to get physicians really interested in managing pain because it tends to be complicated from a prescription management perspective, and also because it just doesn't fit into a 5 or 10 minute appointment. So I usually spend 90 minutes on a new patient visit at least, and that's just face time. And it's really more than 2 hours by the time you write up your notes and dictate the chart and everything else. So in today's medical world, it's really hard to set aside that amount of time to really talk to someone and try and get a good understanding of what their pain problem is all about and how it might be approached in terms of improving it. The last thing I would say on that is that to some extent the medication approach gets a bit oversold. There are a number of medications that are now approved for treating different kinds of chronic pain, especially nerve damage pain, and overall the situation is much, much better than when I was first starting out after going through training. But that said, even the opioids are effective for maybe slightly more than half of patients, but most of them don't really like taking them. They don't like the side effects. And all the other medications that are available to us that are not opioids have just often failed to produce much meaningful benefit. So I always try and have people work as hard as they can on physical therapy, activity management, stretching, proper conditioning, and psychological remedies and strategies, and not over-rely on medications. Allan?
One thing, a difficult question, but I can tell you, I was just actually appointed, and I'm leaving for DC next week. One of the offshoots of the Affordable Care Act was a recognition of the problem of pain in the country. And the Institute of Medicine just came out with a big report. The estimate's like 100 million people have pain at any time during the year, to the point where they actually don't go to work. I have a rotator cuff shoulder. I've got a problem in my leg. I get PT. Blah blah blah. Everyone's got these kind of problems, and they get worse with aging. So they created this agency, Interagency Pain. It's a pan NIH and other government agencies that is really looking at the problem to try to come up with some different way to deal with the problem. But I think Mike illustrated is that a lot of the docs, they don't want to spend the time that it takes. And you hope, it's interesting, he said neurologists don't do, the pain clinics are usually run by the anesthesiologists, right? Not the neurologists, even though it's neurons, nerves, because you can stick local anesthetic and block pain in a quick way, and in some people's that's very effective. But in these types of, some of the conditions we talked about, that's not going to do it. So it's, I said at the beginning, pain is very, very different from the traditional disease model.
Right here.
Can either of you explain the central wind-up theory and whether attempts have been made to identify intervention points between this whole central wind-up occurs?
Well, I got the beginning. I missed the last part of the question.
Like identifying intervention points before the central wind-up occurs?
Okay, what the question relates to is the fact that with repeated injury or ongoing injury, the nervous system, remember I said it's changing, and one of the terms we use is called wind-up. It basically takes input and it sensitizes the central nervous system. Now, under normal circumstances, that's a good thing. If you hurt yourself, you don't want to walk on the broken leg. So you're very hypersensitive. The nervous system has made you aware and you protect. Unfortunately, sometimes that process becomes ingrained. I think of it as just like learning. The nervous system learns, and it can be adaptive learning or it can be maladaptive learning. And the question is, where can we interfere and when can we interfere to prevent this maladaptive learning without interfering with the adaptive part, so that you don't go running around on a broken leg? I can name the drugs that theoretically might work, and they're the same ones that we understand come into play in learning processes in the brain for people who are studying how memories are generated. The problem there, because the same molecules are involved, it would be extremely difficult to treat that process without having cognitive memory side effects. And that's why that target has just been pushed aside. I can tell you what the target is, the NMDA receptor, if you're familiar with it. That would be the holy grail. But that drug is going to make you a basket case. And they did try them, and that's exactly what happened. So the process of learning your children's name or your children's learning is very similar to the process by which the brain and spinal cord learn about the injury and change. And that makes it so difficult to treat, because you're going to end up with horrific side effects. So we got to come up with something else.
I'll just make one more comment about that. So the central nervous system gets involved almost immediately in response to a pain stimulus. And if the generator out in the body tissues stops generating pain impulses, then generally that wind-up will gradually turn off. It'll wind down. And so sometimes when there's an injury to a nerve or to a tissue that isn't healing correctly or is permanently damaged, you keep getting enough signal coming into the central nervous system to maintain this wind-up state essentially indefinitely. And although some of the medications do tone that down, I agree with Allan that if you really wanted to attack it very directly with really powerful medications, then the side effect profile would probably not be very good.
It sounds like we're moving towards the back, so we'll get, I think they cut someone there.
This is a question for both speakers, I guess, but maybe first for you, Dr. Rowbotham, you described some of the patients with postherpetic neuralgia, and with time their pain subsided. Is there any models, or do you know of any theory that it's not the pain that's lessening, but actually the response to pain is strengthening their ability to overcome the pain? So similar to a way that an athlete might condition themselves and maintain strength, but they lose that if they don't continually strengthen. Is there any theory to that a person that's able to tolerate pain is just getting stronger in that part of it?
Yeah, I don't know if the getting strong is quite the right analogy, because it's not something that they can kind of exercise or direct their way out of. It appears to be more that whatever it was that was maintaining the pain gradually subsides. One of the things we did in our natural history study, and hope don't offend anybody with this, but we would actually put chili pepper cream on the area that had been affected by shingles, because that would activate the C fibers that Allan was showing the videotape about. And in the patients with subacute shingles, that would be very painful. We couldn't leave it on for more than a few minutes. As they recovered, this same stimulus no longer really bothered them. It felt warm, it felt hot, but it didn't recreate their shingles pain the way it did early on in the process. And the patients that seemed to really have this persisting sensitivity where they were just kind of barely out of the pain state were the ones that even years later still had this abnormal sensitivity to any kind of stimulation in the area that would activate the pain fibers. The big question is we just don't know of a treatment, either a self-help treatment or a medication treatment or something else that would be administered by a healthcare practitioner that can really reliably accelerate that process. That's where we keep getting stuck.
Okay. You guys have said a lot of interesting stuff tonight, but I think the thing that really struck the deepest chord with me was when you paraphrased your patient who said that to feel pain is to know certainty, and to hear about pain is to know doubt. And I think that's true. And I've experienced anecdotally the truth of that in my own relationships, not only with doctors and insurance people and employers, but even family members, people really close to me. And I can even see it in my own response to other people's account of their pain. So my question is kind of a cultural one. Why do you suppose that truism would seem so apt, given that we all experience acute pain, except unless we have congenital neuralgia, and so many of us experience long-standing pain? Why would we experience or exhibit doubt when we hear about it, from another?
Do you want to tackle that one first?
Obviously I don't have the answer, but what you're saying is absolutely true. And this is the problem. Some people are very empathetic, and the spouse will be empathetic and appreciate and recognize and be supportive, and then other people don't want to hear about it anymore. Because eventually, there's a wonderful article written many years ago in Lancet in the British Journal by Richie Russell, a British neurologist. It's called Pain is an Old Friend. He's referring to chronic pain. What he's referring to is that the individual now lives with pain. They go to bed with pain, they wake up with pain, they're sleeping, the person in the bed next door is not their spouse, it's pain. Their whole life has evolved around this. They changed the way they work. Many of them can't work anymore. And so their whole social interactions are going to change. And for someone to be empathetic and supportive and be able to listen to somebody complaining all the time, the drug didn't work, I can't get out of bed, everything hurts, can you please make dinner for me because I can't do this? Some people don't, after a while, they just can't deal with it anymore. So I don't think it's that they don't want to be empathetic, they just can't deal with it. They can't handle it. I don't know that it's any different dealing with, there are plenty of people who get depressed, and I'm sure, and I'm not a shrink or anything, but But there are probably a lot of people who have a lot of difficulty living with somebody who is chronically depressed. Not everybody can deal with that. It's not all that different. It takes a hell of an individual to be able to handle that, I think.
So I would add to that that if a person develops cancer or they get Alzheimer's disease, it's really not viewed as being their fault. It's something that happened to them. They may have had unfortunate genetic predisposition, but it's not something that was of their own cause. And with pain, because all of us have had acute pain problems that subsided, there's this natural skepticism saying, well, why didn't you recover? Why is it that, the fracture that you had, why are you still having pain? It doesn't fit with their experience. So people tend to quickly wear out hearing about pain problems, or they'll view the person who is describing their pain that there must be something wrong with them, that they must be weak in some way. And we know that that's not true, because if that was true, we would be able to do a much better job of predicting who is going to get chronic pain. But really, psychological factors and life history factors turn out to be very poor predictors of which patients with bad acute pain will go on to have chronic pain.
You touched on the other point, and I said it right at the beginning. You can't see it, right? And I think it is the case that a lot of times you think, well, your pain can't be really as bad as you're saying it is. You may not say that explicitly, but one of the first things I teach the medical students is don't ever assume you know how much pain your patient has. You don't. Everyone's different. And the insurance companies would love to be able to have a number, to be able to say, where's the pain? And it was thought, there was a friend of mine, somebody we know very well, started a company called Descartes. He's a pain guy. And he believed that you could image the brain with modern imaging techniques and be able to see pain, as it were. And there's a sense to believing why that could be, because you definitely, if I took a painful stimulus, I could light up your brain, and I know where it's going to be lit up. But it turns out that you cannot use that imaging pattern, any imaging pattern yet, to be able to correlate or predict use of drugs, amount of pain, etc. His company died. So you can't even get a brain manifestation in an MRI, an fMRI, that will give it to you. And so that's why pain is so complicated, and that's the other reason why there are no pain foundations. Interestingly, thank goodness for the federal government. The federal government is the only one that actually supports research. There are no disease foundations.
Hi, so Michael, you mentioned that one of your treatments for chronic pain, you mentioned psychological treatments. I was curious what kind of treatments they are and how well they work and why you think they work.
Yeah, so I wasn't referring to anything particularly specific. I'm mostly supportive. One of the most effective ones is actually distraction. And it sounds like a truism, that it's important to keep busy. But I have patients that come to me saying, I don't really think I can go to work anymore. I really, I need to, I need to really stay at home and stay in bed or really restrict my activities. And generally, I try and discourage that because it just makes it so that they're going to spend even more time worrying about themselves and worrying about the fact that they're not getting better. And so actually staying active, staying engaged, doesn't mean that you need to live in a state of denial, but to just really try and stay in the world is extremely important for getting better.
All right. I understand. You mentioned acupuncture, and I understand that it is a placebo of some kind. So the question is, given the fact that it sort of works as a placebo, and the question is how effective is it as a placebo, and how long does it last? And even though it's placebo, can you keep using it? I know there's an ethic question about trying something that doesn't work, but is it effective enough to use on some chronic pain?
All placebos would be. But I emphasize again, and I want to spend a little time discussing this because it's a very sensitive subject. Number one, placebos work. And there's been some studies at UC, in fact, a really interesting series of studies where you take out either 1 molar, 2 molars, 3 molars, or 4 molars at the same time. All right? Why anybody would have 4 at the same time is beyond me, but they did this experiment, and then they compared opiates, a narcotic, morphine, say, to placebo. And the more molars you had out, the more likely the placebo was going to be effective. All right? So it's just the opposite of what some people might predict, that, oh, well, you know, you're a crock, there's no pain, that's why the placebo worked. Every element, I teach the medical students, if I am going to, you're my patient, and I say, look, I have this new drug that I've been working with. I'm really excited about it. I know we've been having trouble helping you. I think this is going to be fantastic. I want you to try it for the next 2 weeks. All right, that's one approach. Same drug. Now, you know, John, I'm at my wit's end. You know, I've got this stuff, to be honest, I really don't think it's going to do a damn bit of good. But what the hell, right? Nothing's working, so why don't you take this home for a couple of weeks and see what happens? All right, same drug, but there's something called the nocebo. By the kind of instructions you give, you can actually make the thing work worse than if you told them nothing. So the brain is involved. In acupuncture, why do I say that I believe that acupuncture is a placebo? It's not just my gut that's saying that. It's based on lots of studies. Number one, for pain, and I'm talking about for pain, it doesn't work in children. All right? Children are lousy placebo. They'll respond to mommy who might hug them, but they're not, you know, the white coat comes along with the needle, that's bad news. You think that there's something good in the needle. The kid doesn't think so, right? And it turns out, and this has been studied over and over, it absolutely doesn't make a difference where you put the needles. So the meridian notion, I know all about it. I've studied it. I've read it. It doesn't matter where you put the needles. If it's going to work, it'll work regardless. Now, are there studies out there, proper studies, blind, placebo-controlled, that say that acupuncture works? Absolutely. And we've published them in pain. But if you do the meta-analysis, now you look over the entire field of studies that have been done, it's no better than placebo. Yes, you can always get one study because you had a sample and that group it was better than placebo. So my feeling is the data says that it's not any better, and it will eventually stop working, as do most placebos. And of course, it depends on the magnitude of the pain, the individual, their training, how much they believe in acupuncture. And that's no different from lots of other therapies. All right? Should you go use it? Sure, why not? It's cheap. But if you think it's a placebo, it's probably going to work not as well. It's better if you think it. All right, so don't forget everything I told you.
So I used to be an acupuncture skeptic too, till I actually had acupuncture. So I had this chronic or recurrent right sacroiliac pain, made worse by surfing, and I'd get through the first part of the surf season, come around January or so, it would just get worse and worse and worse, and I'd start getting back spasms. So I went to see this guy who lived in a purple house in Bernal Heights, or the Intermission, and he did massage and did acupuncture, and my God, it was unbelievable.
He did massage
and then acupuncture, right?
Which
right.
one was the one that worked?
Well, the massage was to get ready for the acupuncture, to loosen things up. Anyway. So I was no longer a skeptic about acupuncture. But I do agree, though, with if you keep going back to the placebo, it does eventually stop working. It's not something that you can just keep.
Where did he put the needles?
Well, where it hurt.
I knew, I guessed right. Remember I said it doesn't matter where you put the needles? Except in the case where you actually needle the area that hurts. That's very different. That's not acupuncture. All right? That could be massage, deep tissue, that could be transcutaneous nerve stimulation. If you start to work in the area that hurts, that's not acupuncture. You can call it acupuncture because you use needles, you can put electrodes on it and make them buzz. I'm talking about the more traditional thing that I think we all know when we're talking about.
So I would agree with that. The studies of acupuncture using meridian and other approaches has been that the better designed the study, the less likely it is to show that there's a benefit over a sham acupuncture.
We agree. But they're
I
way in the
have a
back, and then we're
question.
going to.
Apropos of controversial therapies,
Yes?
apropos of controversial therapies, actually, the first part of this question is not. It's really about activity levels and aerobic exercise, but that leads into a potential controversial area, endogenous cannabinoid circuits, and then that leads into another question about marijuana. Can
Okay,
you,
let me answer
address
the
these?
latter question.
Okay.
Because I know something about it. Because I don't exercise, so no, I should. But I'll let Mike deal with the therapy. No, I've studied cannabinoids in the laboratory, and they are incredibly effective in animal models. All right? And they make sense because we understand how it works, how the active ingredient, it's not an opiate. It binds to a different protein, a different receptor. It has a different distribution in the brain. But some of those receptors are absolutely in the pain pathway, if you will. And so there's every reason to believe it should work. And I would have predicted that it should be very effective for pain in humans, based on the biochemistry, the biology, the anatomy, et cetera, and the preclinical work. My reading and my colleagues' reading of the clinical literature, and I don't know what Mike thinks about this, has been pretty disappointing. The papers that have come through the journal that were on this, by and large, were very disappointing. Not all that effective, certainly by comparison to an opiate. And so, yes, for nausea and a variety of other things, for appetite, no question. But for pain in patients, my reading of the literature, not my personal experience, is that it was disappointing.
So back when George Bush was president, remember him? We did a study which was actually funded by the state of California when Arnold Schwarzenegger was governor to do a placebo-controlled trial of smoked marijuana for HIV neuropathy pain. It was published and immediately had like 1,000 hits on the website, and by the next day we were on the Office of Drug Control kind of enemies list. And the study was designed, we included a human experimental pain model on the arm so that the subjects wouldn't really know what to expect from the smoked marijuana. And what we showed was that the marijuana reduced the experimental pain and it reduced their clinical pain. The problem was, and this has really been the problem with all the marijuana studies, is although it does work, the side effect profile is terrible. Most of the patients, and you actually had to have experience with marijuana to be in the study. You weren't eligible otherwise because there was a concern that if we just took people with chronic pain who'd never been exposed to marijuana, that we would turn them into a pothead. And this is San Francisco, so there wasn't really, it was pretty easy to find people that had been exposed to marijuana. So we did the study, and it was potentially biased in that way. But even for these experienced users getting the active marijuana, there were a lot of side effects. And so for the most part, it's not a very good therapeutic strategy. There are some people that feel that it works very well for them and it works consistently, but it does have a bad side effect profile. Now, within the pharmaceutical industry, there's two types of cannabinoid receptors that have been targeted, CB1 and CB2. The CB1 is the one that's associated with all the psychological effects, the sedation and feeling high and everything else. And no one's been able to come up with a good drug that has the analgesic effect without all the other psychoactive effects. So largely, industry has kind of abandoned CB1. So they started looking at CB2, which looked like it might be useful for arthritis. It didn't really have any psychoactive effects, but for the most part, those drugs also failed to work. So, unfortunately, it is an effective strategy, but the ratio between the benefits to just the unpleasant side effects is not very good.
I know we didn't get to the first part of your question. Maybe we'll come back
two questions. First, is there a cultural component to pain? And the second is, what is the mechanism of pain suppression when a person goes into shock?
You want to deal with the shock?
He said, do I want to deal with the shock one? No. I'll let Mike deal with that. The one to the first question, absolutely yes. That there's a huge literature on cultural differences, gender differences. You know of the some people, they want to emote and yell and scream, and that's the way you deal with it. I went to a remarkable meeting in Germany on the anthropology of pain, I think, or pain and anthropological challenge. And they had representatives, all the major religions in the world, talking about how pain is experienced. And it was fascinating. It was completely different in the Hindu world, in Catholic, childbirth in different religions. Pain, it's supposed to be painful. In other cases, not supposed to be painful. The boys are brought up. You're not supposed. Boys aren't supposed to cry. Girls can cry. That's going to influence all these things. Childbirth is an interesting one. We talked about, Lamaze. Everyone knows what Lamaze is. Some women can actually deliver. I wouldn't know personally, but with reduced pain. I would never say no pain because they went through Lamaze. Now, what is Lamaze? Right? They teach you how to breathe. My wife went through it, right? You've been breathing all your life. And you learn about the birth process, you understand anxiety relief, and the magic word that Mike meant, distraction, concentrating on something else. So all these things, these are all societal, cultural, learning, cognitive effects. The soldier who breaks a leg or gets shot in the middle of the war and doesn't have pain till they get back. The football player who doesn't realize that they had severe injury until the game was over. All these things influence the experience, and culture is one of the biggest.
That said, I don't think there isn't a specific religion or culture that you could aspire to where the people don't have pain. It's just expressed differently or perceived differently. But Allan did bring up an important point related to what could be loosely termed psychological approaches, but in addition to distraction, education about pain is extremely valuable because it demystifies the pain experience when people feel like they understand pain, what it's about, how it's affecting them, what it can and cannot do to them. Really helps give them a better framework and perspective and makes it easier to tolerate the pain.
I have a beginner question. How do opiates, aspirin, and ibuprofen reduce pain?
Okay, that's an easy one, at least at the biochemical level. So aspirin, let's deal with aspirin, simplest one. So aspirin is one of these so-called NSAIDs, non-steroidal anti-inflammatory drugs. It targets an enzyme that you've all heard of because you've heard from TV. Thank you. The COX enzyme, cyclooxygenase. That enzyme, it comes into play in the setting of inflammation, arthritis, all right? So what happens is the enzyme is active and it releases a compound called prostaglandin, and that acts on your pain fibers and lowers their threshold, and you become sensitive, hypersensitive. The aspirin blocks that enzyme. That's how it works. That's simple. Now, an interesting aside story I love to tell, true story. I was giving a lecture to, and I tell this to the med students, I was giving a lecture to the general public at the university one day, and I was explaining just that. If you have arthritis, say a knee joint or your elbow, the pill that you take actually works at the site in the elbow, on the nerve fiber way out there, and that's where the enzyme is functioning. All right, it blocks the enzyme and it normalizes the nerve. And the gentleman put his hand up and he says, I have a question. I think it's a dumb question. I said, there's no dumb questions. What is it? He said, how does the aspirin know where to go? And I said, that's brilliant. And I tell that story all the time. The aspirin has no idea where to go. The ibuprofen doesn't know. The naproxen, they're all the same variation on a theme. You take it this way, and that's why you get side effects, because it doesn't know where to go. So targeting drugs to where the problem is the way to work. All right. Opiates. Opiates act largely in the central nervous system, not in the periphery. All right. They work in spinal cord. They work in the brain. They work on receptors, and they basically shut off the firing, they're inhibitory of nerve cells. We know how they do it. We know the receptors. There are drugs that will completely reverse the effect of opiates. But they also are distributed not just in the pain pathways, they're distributed, they can cause respiratory depression. They shut off the breathing apparatus. They give you a high. A junkie is not taking heroin because they want to get pain relief or they want to get constipation. They want a high. There's a part of your brain that triggers that. What was the other drug, the last one? Who? Oh, ibuprofen is just like aspirin.
Now, the interesting thing about opioids is that they're effective for just about every kind of pain. And, but there are situations where aspirin and ibuprofen and the non-steroidal anti-inflammatory drugs are actually more effective than opioids, and that's generally things like tooth extraction and other things that involve acute inflammation. Yes.
Okay. So a slight diversion, but it's neurological, I think, and that is, how does this tie in with things like tinnitus?
Tinnitus. I think this is probably a stretch, but tinnitus is a perception that relates to loss of nerve fibers in the auditory system. And to some extent, patients who have neuropathic pain have the normal sensation replaced by a foreign or an abnormal sensation that is there all the time, and it can be burning, it can be tingling, it can be any one of a number of different things. And in that way, it's analogous to tinnitus. And in both cases, they're awfully hard to shut off, right? I mean, there really are no good treatments for tinnitus to make that go away.
I don't know the answer to the question, but I'll give you a name to search on. Michael Kilgard, K-I-L-G-A-R-D, he's at Rice. He's a very smart guy who studies tinnitus. He happened to contact me in part because he thought that our understanding of some of the biology of neuropathic pain might be relevant. He's working on techniques to try to suppress the experience. It's an abnormal experience. But you'll probably learn a lot from reading his work, but other than that, I can't tell you anything.
I'm interested in the effects of hypnotism on pain.
Okay, that came up, somebody asked me earlier. It's the end of my pain lectures to the medical students. I happen to think that, all right, so let me step back a second. Many therapies, including placebo, by the way, act via, at least in part, via release of the endorphins in the brain. These are the endogenous opioids. Now, you take morphine, the way morphine works is it binds its target, the opiate receptors, but morphine is a plant-derived drug. Morphine is mimicking the endorphins, the endogenous morphine-like compounds. The endorphins are neurotransmitters distributed in the brain, and one of the things they can do is block pain. The story of the runner's high or the pain relief, there's some truth to that you release endorphins and that will suppress pain. You can block the effect of the endorphins or morphine with a drug called naloxone. It's just an antagonist. So placebo can be blocked by naloxone. All right? The data is very strong. What that says is placebos, psychological factors, can cause the release of endorphins. Hypnotic analgesia does not. Hypnotic analgesia, I happen to believe, can be very effective for certain people, but it does not involve the endorphins. Because if you give naloxone to somebody, there's quite a few studies in this, in which you can create a hypnotic effect and reduce their pain, naloxone won't touch it. So it's a different mechanism. The brain is engaged, and the most dramatic study that's ever been done was done by Hilgard, and Michael will probably think this is a crock, but it's an impressive study. Hilgard was a very renowned psychologist at Stanford and also a hypnotist, wrote a lot about hypnotism, and he studied pain and hypnotism. And he did a very famous study that goes something like this. You take an individual and you put a blood pressure cuff on their arm and blow it up, not to the point where it's paralyzed, but to the point where if you now dip it in ice cold water, it's excruciatingly painful. Excruciatingly painful. And the subject will tell you it's excruciatingly painful. Then he hypnotized them so they didn't feel pain. They didn't report pain. They actually said, no, it's fine. I feel, you sure? Yeah, I feel absolutely fine. Great, okay. So they were able to control it. And then through a process that I don't understand, he tapped into the, if you will, the subconscious. It's called the hidden observer in the field. The little woman or man in the brain, your subconscious. And he asked the hidden observer, through this some hypnotic process, what do you really feel? Tell me what you're really feeling. Now, the person's saying, I feel absolutely great. I feel fine. No problem, no. But then they used something called automatic writing, where the hidden observer could talk to you, respond to you by writing answers. I mean, it's Twilight Zone type stuff. But so the hidden observer is answering and saying, Jesus, this hurts like hell, it's burning, it's terrible, stop it. I feel completely fine, no problem at all, absolutely. And the hand is going crazy. It is a freaky experiment. You can read about it, it's published. Why do I tell the story? Because it says, and it's not reversed by naloxone, remember, so a different mechanism. The information clearly got to the brain. In many of these other therapies, placebo, morphine, you're blocking the pathway by which the information is transmitted. It never gets to the brain. The perception is never even generated. That's the idea. Hypnosis, you alter the perception. I'm a believer in it. Have I used it? No. It's just my reading. This is my sense of reading of the literature and knowing some of the people. A guy named Donald Price in Florida, who's one of the aficionados and wrote the book on hypnosis and pain. So I'm a believer, and I have no idea whether Michael would advocate it.
It's hard to find a good practitioner, actually, to do that. And obviously, it's inconvenient for trying to get through activities of daily life if you have to be in a hypnotic state. But it does work. Yes.
I believe you said that physical therapy can be an effective strategy. And I was wondering what you both think about what they call cranial therapy or sacrocranial therapy, which is concentrated on the head and neck, and it's not as, some people think that it's a crock, and I'd like to know what you think.
I actually have a friend who had treated his own spinal problems with craniosacral therapy. I can't say I really understand how it works. It really seems to the approach is to try and improve overall body alignment, and it's very subtle, sort of straightening and other things. Now, whether or not this is relaxation, whether or not what other aspects go into it, I really can't say. And anybody in the audience that might want to educate both of us a little more about the subtleties of craniosacral therapy, you'd be welcome to hear from them.
I know nothing about it. I do see a physical therapist because I have a rotator cuff problem and I'm trying to avoid surgery. But I will say this, and if you had asked me 2 years ago, and I happen to, I was married many years, my wife died, but fortunately I remarried, and I happened to remarry somebody who is a real yoga aficionado. And I'm not the most spiritual guy in the world, so I'm not into, but I started doing yoga with her, with the Marquis de Sade's sister is our yoga teacher. I mean, she's something else, but I will say that since I've done this, and we had an hour this morning, it's hell, but it's the best thing that I've ever done for when I get up in the morning, things don't hurt anymore. For me, it's stretching and all that. That definitely is going to help. I have no idea what the other thing is, but so I do think that relates back to the earlier question. I think manipulating, massage, stretching, exercise, absolutely is going to make a difference. These things are all going to help. I do want, before we close, I want to show these. All right, I want to tell you something, because I didn't want to bring it up, I mean, in the thing, because, so I'm a scientist, I mean, and I'm interested in maybe new ways, in trying to identify new targets and stuff, but one of the things I did tell you is that I believe that, especially with neuropathic pain, where there's changes in the nervous system, that there is a disease process going on. Okay. Now, when you try to treat diabetes, you give a person insulin, you're treating, but you're not treating the disease, right? You're trying to overcome the problem. If you do a pancreas transplant, you might be treating the disease. In my opinion, some of the major things that go wrong in the central nervous system is a loss of inhibition, all right? And we know that from many animal studies, that in many ways, some of these conditions are like epilepsy. And in fact, the drugs that are often used to treat neuropathic pain are anticonvulsants. Not necessarily good ones, but many of them are anticonvulsants. So you're trying to suppress the inhibition. I mean, you're trying to increase the lost inhibition, which is what you're trying to do to prevent seizures. What we asked, and we've been working on this and we're very excited about it, I'm going to show you a few slides just to make the point, is can we actually repair the nervous system by replacing the cells that are screwed up, that are either dead or not functioning? And we know that's the case. And what we have done is we have taken, in this case, and these are studies in the mouse, and now we're using human embryonic stem cells and iPS cells, and I'm not going to go into the details. I'm going to show you just how dramatic the nervous system is, how plastic it is. So here I'm going to show you transplants of embryonic mouse brain, the area of the brain that makes all the inhibitory cells for the cortex, for the cerebral cortex, not for the spinal cord. The problem's in the spinal cord in these models, just like it is in many humans. But we know we can get those cells from an embryo, and we transplanted them. It had been done in an epilepsy model, and I was impressed. And I said, I went to my friends, I said, do you think we could try it in the cord? He said, you can try it, it probably won't work because the cells don't belong there. They'll die, they won't survive, it's the wrong environment. They belong in the cortex. Well, that's what science is about, you try things. So we did try it. So we're transplanting these cells, and what I can tell you is not only do they survive and integrate and form new circuits, but they can actually treat many conditions, including chemotherapy-induced hypersensitivity, traumatic injuries, and now we're getting the same results with human cells, embryonic stem cells that are modified to become inhibitory neurons.